welcome.
Is it recording?
Windows Zoom meeting.
Hello, welcome everyone. My name is Alexandria Griffith, and I am part of the ADRC team at the California Department of Aging. Today, facilitating with me is Amanda Price. Thank you for taking the time to be part of today's ADRC Fridays Roundtable series. As speakers introduce themselves today, we will use a visual description. I am American of Filipino descent with dark brown hair. Today I am wearing a dark blue shirt. Thanks to ADRC teammate Mylene Ickmat for her support running Zoom today. And please say hello to the rest of the ADRC team: David Morikawa, Jeanette Fong, Rosie Carvajal, Carol DeAndres, and Amanda Price. Reminder, we are seeking promising practices submissions and would like to encourage you all to take part by sharing program practices that have contributed to developing person-centered practices and establishing a no wrong door system. The first quarterly submission deadline was extended to May 18th, 2022. Just an overview of some logistics to start. We will have polls, remarks from one ADRC and CDA staff, and breakout rooms during the 1 hour today. You are able to mute and unmute yourself throughout the roundtable, and there will be plenty of time for you to connect with each other and share your questions and ADRC practices in the breakout sessions. If you are dialing in, please dial *9 to raise your hand and *6 to unmute. Chat is enabled for all of you today to share comments with each other during the hour. And the live transcript button on the Zoom toolbar is available. We are recording this roundtable, and the recording will be made available on the ADRC Library tab on the ADRC Partners and Providers website. If you're having technical issues with Zoom, please email adrc@aging.ca.gov. So with that, let's start a quick poll. Please welcome Amanda.
Hello, everyone. My name is Amanda Price, and I am Anglo middle-aged with long blonde gray hair. And today I'm wearing a blue sweater and glasses. So I will launch our first poll, and it is displaying right now, or it should be. What type of organization are you part of? And please answer one of the following. If you are part of a AAA, an ILC, another ADRC partner, or another organization servicing LTSS consumers, or other. And then the next part of the poll is, what sport would you compete in if you were in the Summer Olympics? And we have choices: swimming, gymnastics, track and field, other, or I'd rather be watching the Olympics. So I see some responses still coming in, so we'll give it a few more seconds. And thank you all. Okay, so looks like we are at about even for our ADRC partners. And thank you all for coming today to this roundtable. And then in terms of what sport, it does appear that swimming has a slight edge over perhaps track and field and gymnastics. And then there's also a fair number of us, probably me included, that would rather be watching the Olympics. So thank you all. And I'll turn it back to Alex. Thank you.
Thank you, Amanda. Today's topic is about developing ADRC leadership and partnerships, building a community network. A special thanks to Marin Center of Independent Living for sharing their practices today.
Nothing
To get us
required.
started on this topic of developing ADRC leadership and partnerships, please welcome Marin Center of Independent Living, Julia Hales and Anna Kachatrian. Julia and Anna, thank you for sharing some of Marin's successful partnership development practices.
Julia, we can't hear you. You need to unmute yourself. Hello, everyone. I'm Anna Khachaturian.
And I'm Julia Hales. Apologies. So just to share a little bit about some of the partnerships we have developed, I just want to share that, first and foremost, we have had for the past 4.5 years a nursing student internship, which I know is very unique because, again, we are an independent living center. And while, really we address the social determinants of health, we have recognized that we really need to build partnerships with medical care providers. So we were able, through our AAA 4.5 years ago, to begin this internship program with our AAA had a public health nurse on staff who was able to oversee our interns. And so we began with our local colleges and universities to develop an opportunity for their students to work with us. And we have found that there has been a great lack of internships available for nursing students in the Bay Area. And so throughout our nursing internship, we have been able to gather or garner up to 50 students at a time who have made such a huge bridge. They have in terms of providing care. So through the nursing internship program, we are able, while we address as an independent living center the social determinants of health, the nursing internship program has been able to identify and address medical needs such as medication management, access to care, and accessibility issues, just to name a few. Our nursing internship program has blossomed, especially during the COVID pandemic. We have been able to have more interns than ever, and it has been invaluable to have boots on the ground because our independent living center has been working remotely, and these nursing interns have been out there, boots on the ground, providing medication management, weekly check-ins, medical evaluations, and referrals for things like physical therapy, additional specialist support. And it really has been just such an enriching part of our program as an ADRC. Because again, while we address the social determinants of health and provide short-term service coordination and transition support, it's our nursing interns who are going out there and making sure after, for example, someone has transitioned from a skilled nursing facility to home, they're the ones who are able to go out there and make sure, are they getting their medications? Is there follow-up from, for example, Sutter care at home? Are they getting the physical therapy and occupational therapy they need? And if not, they and their supervisors are able to help refer for greater levels of care. And so this internship has just been, as I said, invaluable. We were able to hire through a grant a nurse who oversees the internship now, since through the AAA, the previous public health nurse has moved on to other positions. We now have a dedicated staff member who is able to help make sure that we are balancing sort of the medical needs as well as the independent living needs. We meet every week, sometimes a couple times a week, and are able to sort of case conference each individual and make sure that we are referring the appropriate services for them. The other thing I wish to talk about is our local ombudsman partnership. Now, when I began almost 6 years ago, I was our sort of transition point person, and we have since been able to hire someone, Armin Anwar Damani, who is our transitions navigator. And so through the efforts of Armin and myself, we have been able to develop a very strong partnership with our local ombudsman. And I just cannot emphasize enough how important it is to have a strong relationship with your ombudsman. Armin and I meet with them once a month. Armin meets with their team members probably 2 to 3 times a week. And through this partnership, we have been able to really guarantee safe and lasting transitions from skilled nursing facilities back to community-based living. There have been times where, I've tried to advocate, just for my own experience in the past, I've tried to advocate for how, I wasn't sure that it would be a safe discharge, for example. And I've been able to really call upon the ombudsman, and they have stepped up. And I mean, not just stepped up, they're amazing. But we've worked collaboratively to really make sure that every transition out of a skilled nursing facility is as safe as possible. And that includes making sure that skilled nursing facility staff goes and does a home check to make sure whether or not the home is actually safe for someone to be discharged to. We also have worked a lot with the ombudsman around, again, with our longer term consumers who have been in skilled nursing facilities for maybe 2 to 4+ years, and to try and develop a plan to safely transition them back to community-based living. And that really has proven just invaluable. We have found, in Marin, there are times where our nursing facilities will try to discharge someone to, a motel, and count that as, a safe discharge. And so really with this partnership, we have been able to say, we need to think about the longer term, not just one night, not 2 nights. We need to think about 30 days, 60 days, 90 days. And how can we make sure that people with disabilities are supported? So I just really encourage all independent living centers and all ADRCs to really collaborate with their ombudsman and make sure that you have some kind of working relationship, because they are sort of the regulating partners or regulating bodies who really oversee sort of the safety and can also advocate along with us, because sometimes one voice isn't enough. And I'm going to turn it over to Anna to speak about community clinics.
Hi again, I'm Anna Khachaturian, the Community Care Administrator at Marin CIL, and I oversee the M3C partnership program between Marin CIL and Marin Community Clinics. M3C stands for Marin Community Care Collaborative. And since 2019, MCC and Marin CIL have worked in close partnership to strategically leverage resources that expand the capacities of both organizations to provide person-centered care coordination for either medical beneficiaries or people without insurance who live with a disability in Marin County. So how did all this started? I'll share a little bit about the history of M3C. Marin CIL learned through discussion with many of Marin's healthcare providers that there is a limited capacity to adequately and successfully address the needs of individuals who use long-term services and support. Some of those care coordination challenges included patients who were discharged from hospitals didn't have appropriate support, for example, caregivers, durable medical equipment in order to live independently, and address psychological needs, especially with new disability. Other care coordination challenges were that discharge plans were so difficult for consumers and family members to understand and follow. Patients experienced linguistic and cultural barriers accessing IHSS, social services, and other community-based programs, and that the communication with rehab centers were so challenging. So what Marine CIL did, we came up with integrated model of care, which included seamless transitions between hospitals and home, decreased caregiver stress, reduction of unnecessary hospitalization and readmission, diverting or preventing nursing home placement, and of course, cost savings for medical providers and health plans. And most importantly, we wanted to improve patients' quality of life. Marine CIL wanted to achieve triple aim: to address social determinants of health, improve patients' or clients' experience with care providers, and improve quality of life. So then we started with a pilot phase, M3C's pilot phase. And the goal for patients enrolled in the pilot phase, which was about a 6-month-long pilot, and the goal was to enroll 15 to 20 patients. Some of the goals for patients enrolled in the pilot were housing security, ability to remain living safely in one's home, or preventing homelessness, hospitalization, reduction in emergency department visits and hospitals need readmission. And definitely that would have helped to reduce the healthcare costs. Increased access to public programs, including food and nutrition, reduction in depression or isolation, increased self-sufficiency and ability to perform activities of daily living, and improved patient experience with health and social services. The patients who were enrolled in the pilot phase had to be identified as having the disability, be enrolled in whole person care or IOPCM programs, just these two programs at first for the pilot phase, and express interest in Marine CIL services, reside in Marin County, and preferably speak English, because back then I was the only one overseeing the program. Even though I speak Armenian and Russian, we didn't see a strong need in the community. Some of the circumstances may include the following: patients who were recently diagnosed with disability, traumatic brain injury, who experienced homelessness or were precariously housed and transitioning from long-term care or in need of caregiver, durable medical equipment, or home modification. So later we realized after the pilot phase that there is a huge need in the Latino community, and there were so many Spanish-speaking clients who could be enrolled in this program and benefit from it. So what we've done, Marine CIL increased its capacity in 2021 to serve monolingual Spanish speaker by adding a care navigator to the M3C team who is bilingual and bicultural, and it was mid-year 2021, but about 1/3 of MCC patients engaged in Marine CIL services were Spanish speakers last year in 2021. Also, we realized that Marine CIL care coordination services were needed, even when MCC patients were engaged in programs that aim to provide care coordination services, such as whole person care, IOPCM, LICN, Ryan White, and whole child care programs. If you would like to know, I'm not sure if you know about these programs. I can briefly tell you about these programs, or maybe after the meeting, because I know our time is limited. If you have any questions about these programs, you can ask and I can explain more. But we realized that there is a need, and during the partnership phase of the M3C program, we accepted referrals from from Marine community clinics to patients who were enrolled in these programs as well. Often, MCC patients are referred to Marine CIL for specific issue, and after Marine CIL asks questions, we find out that there is more. We find out about the need, and then we address those social needs by providing different services. We usually do pre and post wellness tracker survey. That wellness tracker survey also is an assessment tool for us to identify other needs that aren't mentioned by MCC. So we think outside of the box, and this is a wonderful program, and about 94% of the referred patients are enrolled in the program currently and are actively participating in receiving services by Marine CIL. Thank you, and I'm not sure when is the time to ask questions. I will be happy to answer if you have any questions.
Yes, thank you, Julia and Anna, for sharing about your successful internship program and your Thriving Ombudsman partnership and the community clinics pilot phase. We'd like to pause here for questions from the group today. Do you have questions for Julia and Anna? And if so, you can unmute yourself or put your question in the chat. Some are already here in the chat. We have a question from Maggie Kraft. When it is question time, what nursing schools are you partnering with? We have wanted to do this in PSA 1, but our local nursing programs do more of brief student rotations versus interns assigned for a whole semester to one agency. Would love to see details of your model.
So I would be happy to share more information. As I just put into the chat, the universities we typically work with, we found during the pandemic that more universities than ever were really looking for placements for their students. So we actually had about 20 students from Harvard, 20 from Sonoma State, and I believe it was 8 from UC Davis. I will say, at times, there's been concern expressed about the fact that students are only available for 2 to 3 months, but having a nurse, our nurse supervisor, she really has made sure that there's a continuum of care. She will go out into homes. She's in Marin 3 times a week. And she meets with our consumers in between those student bodies. And then in terms of just looking at the chat, Anson, I just want to say the name of our assessment is our quality of life survey, or we also call our wellness survey. And I would be happy to share that with everyone via email.
It's only 7 questions. It measures the social determinants of health.
Exactly.
Great, excellent. It looks like we can paste the website into the chat if that's helpful. And we will come back to questions towards the end. And for right now, we will move on to our next speaker. Now, please welcome Rosie Carvajal from the Department of Aging. Rosie will be sharing some resources related to ADRC partnership development, which are found on the CDA ADRC website. Rosie, thank you for being here today.
Thank you, Alex. Hello, my name is Rosie Carvajal. I am American Asian female, middle-aged, with short black hair and glasses, and wearing white today. Today, we would like to do a brief overview of where the partnership development resources are located on our ADRC website. Here is an image of the ADRC website, drawing special attention to the tab Establishing an ADRC. I'd like to share a few documents that may be most helpful to you. They are indicated in the red stars. The first one, once again, is under the Establishing an ADRC tab, is making the most of ADRC partnership planning. This planning tool for local partnerships is used to streamline the planning and development process, in addition to providing important background and context to local discussions. The next resource found under that link is the ADRC self-assessment tool. This is a self-administered ADRC readiness review document intended to track the progress toward building the organizational relationships necessary for the success of an ADRC partnership in California. With this tool, core partners can assess their own level of readiness to finalize details necessary to meet the state's ADRC designation criteria. The last resource on this tab draw your attention to is the ADRC Core Partner MOU sample. This is a sample MOU template that can be used by ADRC core partners for outlining partnership expectations and facilitating positive local ADRC partnerships. Next, this is an image of the ADRC website to help you find what I'm talking about. Draw special attention to the tab Infrastructure Grants. Once on the Infrastructure Grants tab, you'll notice many available resources. One I'd like to bring to your attention is at the very bottom. So once you're on this tab, you're going to scroll all the way to the bottom. Look for the blue Reporting Template and Instructions drop-down menu. There you will find a document when you do the drop-down menu. It's called Sample ADRC Development Work Plans. This resource is intended to help outline your ADRC's vision, organize strategies that you want to put into action, and prioritize goals and objectives. And it's an option to use this work plan, and it is in Word, so you can manipulate it. We highly recommend it because there's a lot of really good resources on it. So as I mentioned earlier, all of these resources can be found on the CDA ADRC website. If you have any questions, please let me know. Thank you.
Thank you, Rosie, for sharing the ADRC resources. I'd like to pause here again for questions, if anyone has questions on where to find these resources. Please feel free to unmute yourself or put your question into the chat. I see David Wiltsey is raising your hand. Are you able to unmute here?
Can we unmute David?
I pressed the button. Oh, here we go.
Does the state have a process for evaluating individual ADRCs?
Can you be a little bit more specific? So to designate them? Oh,
I'm with Area 4. We have 7 counties. We now have 4 ADRCs established. And as an advisory council member, I'm having a devil of a time trying to find out how effective these organizations are. Does the state have a formal process for evaluating the performance of ADRCs and suggesting improvements?
Thank you, David, for your question. Currently, to establish an ADRC is what the evaluation tool, which is posted on there. Currently in development is a monitoring practice. We are currently developing a way to monitor ADRCs. It's not yet set in place yet, but we are working towards that. Thank you for your question.
Thank you.
I see some suggestions for roundtable topics. Thank you, Jan. Okay, thank you, Julia, Anna, and Rosie for sharing today. We are going to move on to our breakout rooms to continue today's conversation. So please assign a person to report out in your breakout session. And maybe if you do notice what breakout room number you're in, there's going to be a total of 4 and there will be a number in when you're in your breakout room. So here are some questions to consider when you're talking with one another in your breakout rooms. What are the easier partnerships to develop? And what are the more difficult partnerships to develop? Our second question is, what aspects of building partnerships has worked the best or least for you and your team? And with that, we will move into our breakout rooms for our roundtable discussion.
Got it.
Thank you, Mylene.
You're welcome.
Quick question. Could we put the questions on the chat?
Yes,
Thank you very much.
absolutely. Of course.
Got it.
Thank you.
You're welcome. And then I'll put everyone back, admit all the other ones.
Yes, thank you.
There we go.
Great, seeing everyone coming back. Thank you all. Thank you all for your participation today. Were there any takeaways anyone would like to share here at the larger roundtable with all of us?
Well, this is David. I can maybe break the ice here a little bit, but our group did discuss a little bit about trying to develop more partnerships, not just with the non-medical agencies, but also with the medical provider agencies as well. And so this way consumers, when they call in and need to have navigation to support their interests, they would be able to have both medical and non-medical service referrals made available.
Thank you for sharing, David.
I'll jump in. Just say, in breakout room 4, we were able to talk a bit about our various partnerships and how, especially for those of us where our AAAs are housed within aging and adult services, it has really enabled us to have strong connections with our ombudsman program. And we all have found that to be invaluable, just because of the advocacy and support that the ombudsmen are able to provide. Another thing that came up was with the unrolling of CalAIM and how varied that is across the state. I shared for Marin County, our aging and adult services currently has declined to participate in CalAIM because of the requirements that Partnership Health Plan, which is our Medi-Cal provider, or managed healthcare plan, is offering. And so, it's sort of a real barrier for us. And sort of a stump in terms of how can we find any other alternatives. And I mean, we do have this relationship with Marin Community Clinics that, you know, our local FQHC, where we're exploring how can we participate in CalAIM. But, you know, I think, all thought that in terms of developing partnerships, we would have an automatic in with CalAIM, and that just has not been the case. And, you know, we're providing so many services that are in line with a lot of the CalAIM goals, and especially the enhanced case management and in lieu of services supports. And so that's a real challenge, is how to navigate. How can we make sure that, you know, we're at the table?
Thank you for sharing, Julia. I see that Britt Bassoni shared in the chat. Failed to mention in the breakout room, but the ADRC charge to build service bridges and develop partnerships also allows them to serve as value-added entities in being able to introduce providers to one another and make connections between formerly unfamiliar community providers. Thank you for sharing, Britt. Any more takers?
I'll raise my hand here. I'm sitting here moving trying to get myself in the light, too late. I have a question. I'm just struck by Julia saying that their organization is not going to be accepting CalAIM, which I just kind of think, oh my gosh, what, you know, all the money and time they've spent on that. Are there any other areas who have found the same, found the same conundrum and not wanting to, and not accepting CalAIM? I just was kind of curious I'm dental, so I'm a non-medical. Does anybody else, any of the other organizations finding the same barriers that Julia has found?
Thank you, Elena.
I'll just add that after meeting this week with the person who oversees our whole person care and coordinated entry, that they said CalAIM has taken away the legal foundation for the work they're doing. And while I have, some of you might know, plenty of criticisms of whole person care, at least in Marin County, the loss of that legal foundation and the ability to do the work they're doing is enormous. So it's just a very sort of unsettling time in my eyes in terms of how can we move forward. And also, I personally thought CalAIM was going to be a lot more accessible than it is. And it's honestly disconcerting that this is where we are.
Thank you, Julia, for sharing. As we wrap up today, thank you everyone for your participation. Thank you to our speakers, Julia, Anna, and Rosie. A reminder that the ADRC team is here to support. Please email adrc@aging.ca.gov anytime. As we end today, we would like to hear from you about this session. Amanda, can you please post the final poll? After you respond to the poll, feel free to log off and have a wonderful weekend. Thank you, everyone.
Thank you all. And I'll read the questions just as you're answering them. Overall, how would you rate the quality of this session? It's a single choice from excellent to very good, good, fair, and poor. And what type of format would you like to see more of in these roundtables? Single choice, more open discussion time, more breakout room time, more local partner ADRC presentations, or okay as is. And thank you all for responding. That helps direct future sessions. And have a good weekend, everyone. Thank you.
Thank you, Amanda.
Happy Friday, everyone.
Happy Friday. Thank you.
Happy Friday, everyone, too.
Friday.
Thank you, Maria.
You're welcome. Thanks.